Thank you for registering for the first ECMO course through STS University. Your course directors are Dr. Helen Marie Merritt, Dr. Jay Zwischenberger, and Dr. Eddie Suarez. For the purposes of this course, the terms ECMO and ECLS will be used interchangeably. ECMO has been around since 1990, but has really been on the rise for the past 10 years. In 2018 alone, over 12,000 cases were performed at 420 unique centers. For this reason, standardization of ECMO care and patient selection is necessary. Expected outcomes depend primarily on the indication for support, with respiratory ECMO having a survival rate through hospital discharge of about 60%, compared to cardiac ECMO about 40% and ECPR about 29%. As you start considering ECMO at your institution, you first need to answer one big question. Will your program initiate ECMO for failing patients and then transfer to a larger center, or will you keep the patient throughout their ECMO and their recovery? ELSO guidelines state that tertiary care centers with either a NICU, PICU, or adult ICU should be used as ECMO centers, and these centers should be in a geographic area that can support a minimum of 6 ECMO patients per year. Otherwise, the cost and expertise to support these patients is not available. ELSO guidelines also suggest that any ECMO center should be actively involved in ELSO, including participation in the ECMO registry. ELSO also comments on program structures within ECMO centers. The ECMO director must be a physician who is boarded in their specialty and who has received additional training in ECMO support. You must also supply a ECMO-trained physician who will be available around the clock, who has additionally completed 3 years of postgraduate training and has ECMO training as well. In addition, an ECMO specialist is required who can troubleshoot any of the equipment and provide daily rounds and education. This ECMO specialist must have a strong interest in ICU, at least a year, and also have passed qualifying exams in either respiratory therapy, nursing, perfusion, or medical training. An ECMO program structure typically consists of an ECMO director, which may be a co-directorship between medical and surgical directors, an ECMO quality manager, an ECMO coordinator, and an ECMO educator. Each of these roles are vital in maintaining the organization of the structure. You will also need certain equipment if you plan to house ECMO within your ICU. You will need to be able to check anticoagulation, either with ACT or other means, at the bedside. You will need backup components, adequate lighting for surgical procedures, and adequate instruments for revision or exploration of cannula sites. You'll also need at least double of all of the equipment that you're presently utilizing in case of emergency. As you institute ECMO at your institution, there will be several other questions which will arise. Who will you cannulate? Who will do the cannulation? Will you transfer the patient or keep them? Who will sit bedside, nursing or perfusion? How will you cannulate? Will you cut down? Will you do percutaneous access? When will you start anticoagulation? What will you use to follow it? When will you feed the patients, bathe them? Will you let them be awake? Will you plan to ambulate patients on ECMO? You'll need a lot of checklists, algorithms, and collaboration. Here are a few examples of checklists. We'll move on to discussing cardiac or VA ECMO. These terms will be used interchangeably. The indications for cardiac ECMO include severe cardiogenic shock refractory to any medical therapy, heart failure with severe pulmonary failure, ventricular arrhythmias like VTAC or VFib, massive pulmonary embolus with hemodynamic compromise, ECPR, which we will discuss separately, acute MI with hemodynamic instability refractory to medical management, myocarditis, and post-cardiotomy shock. Contraindications to VA ECMO include multisystem organ failure with acute or chronic decompensation, CPR for greater than 30 minutes without adequate tissue perfusion, recent stroke or head bleed, severe peripheral vascular disease, severe aortic insufficiency or dissection, and patients who are not a candidate for VAD or transplant who do not appear to have a recoverable heart. Also, compliance issues, including social or cognitive ability, may be considered. The SAVE score, Surviving After VA ECMO, was developed to help determine a patient's chance at recovery and is based on several things: patient's diagnosis, their age, their weight, and the severity of their illness, including hemodynamic numbers, prior to initiation of ECMO. The lower the score, the lower the patient's chance of survival is. Once you've identified an appropriate patient for ECMO, you'll need a well-organized plan of attack. This starts before the first consultation. You'll need to have a bedside, as well as lead RN or ECMO specialist, your ICU doctor, your perfusionist, your respiratory therapist, the surgeon, and an assistant available. You'll also want to have on hand antibiotics, anticoagulation, and an ultrasound. We have an ECMO box we bring for every cannulation. This box includes the essentials to avoid running back and forth to the unit or to the OR to get additional supplies in emergency settings. Below is an example of our ECMO Box Supplies. There are many different configurations of ECLS for VA ECMO. The most common to the cardiac surgeon will be VA Central Cannulation, which often involves using the cannulas used for an initial operation to support a post-cardiotomy patient. The chest is left open in this instant in anticipation of frequent takebacks for bleeding or for revision. The second type of configuration involves peripheral cannulation, which may be done either percutaneously or through an open approach. A distal perfusion catheter is necessary to prevent limb ischemia in most instances. This will be discussed further during class. The last type of configuration for VA ECMO involves using the axillary artery and typically a chimney graft to allow for bidirectional flow. You will want to sort out the most common ways that you will cannulate for VA ECMO and have a reference card available for quick reference that details patient's body size and the cannula that you would choose for each configuration. Once you've initiated VA ECMO, you'll want to check a few things: the flow, the FiO2, the O2 sat, the mixed venous, the SpO2, the CO2, the MAP, the pH, platelet count, and hematocrit. Here are some goals for initiation after VA ECMO. You'll also want to have a checklist looking at the ABG from both the circuit and the oxygenator, as well as how the cannulas are secure, and an X-ray. Complications of VA ECMO are not infrequent. It is important to have a high index of suspicion for early recognition and treatment for each of these complications. Neurologic deficits in the form of embolic events or brain bleeds occur between 10 and 30%. Bleeding, embolic events, and limb ischemia are the other Achilles heels of VA ECMO. Specifically, limb ischemia can affect between 15 to 50% of patients, with up to 15% of these patients requiring a fasciotomy and another 15% requiring amputation. A post-cannulation vascular scan of the lower limb by a trained vascular sonographer is recommended to confirm the position of the distal perfusion cannula and describe the adequacy of lower extremity perfusion in both limbs. Many centers also advocate for the use of tissue oximetry and for collaboration early and often between vascular surgeon and the remainder of the team. Hyperperfusion is another more rare but also dangerous situation that can occur after graft placement is utilized for ECMO support and the limb receives overperfusion in comparison to the rest of the body. A unique phenomenon occurs during peripheral VA cannulation called Harlequin syndrome, where there is a cloud of mixing from the oxygenated VA ECMO circuit and a cloud of deoxygenated blood from the patient's own lungs and native circulation. Initially, the patient's heart is so weak that most of the oxygenation comes from the circuit and will adequately allow for tissue perfusion of the upper extremities and head. However, as the patient's heart recovers, it may start to push deoxygenated blood from the patient's own respiratory system into the head and the upper extremity. This may manifest in a decrease in cerebral or tissue saturations and may require VAV ECMO, where a second drainage cannula is used to completely decompress the heart. How will you know when your patient is ready for decannulation? Well, your patient may be ready when their pulse pressure begins to recover and when the amount of inotropic support has substantially decreased. This usually takes at least 48 hours, though the timing may vary based on indication of support and severity of illness. An echo, either TTE or TEE, may be used for guidance during the weaning process, which should take place slowly, and the patient should be anticoagulated unless there is a major contraindication as you decrease flow. Start by looking at the patient's initial hemodynamics and decreasing the flow by 1 liter per minute. Stand at the bedside and watch the hemodynamics. Then gradually decrease to half the flow. In patients whom you aren't sure will fly off of ECMO, you may even consider recirculation for between 30 to 60 minutes while continuously flushing the cannula every 10 minutes or so in order to preserve the circuit in case you need to reestablish flow. Remember that there are 3 outcomes available for VA ECMO. The patient may wean, in which we expect a recovery within 7 days. In this case, decannulation occurs in the operating room with primary repair of the femoral vessels. The patient may be bridged either to a transplant or durable support system if they have recovered organ systems. Usually, we try to shoot for this within a week's time. And the patient also may go to palliation if there are no other viable options existing. Involvement of a palliative care team is useful in these instances. ECMO in the setting of CPR has also been described. Those survival rates are not as good as cardiac CPR. For example, survival to discharge for cardiac or VA CPR is about 43% compared with ECPR, which has a survival to discharge of about 29%. However, all indications and contraindications for VA ECMO are applied for ECMO in the setting of CPR. This should be used for patients who have had an event which can be easily reversed and who have had excellent CPR. ECPR may be considered for prolonged CPR if good perfusion and metabolic support is documented, but should be considered early in the process, especially for unsuccessful CPR with no ROSC for the setting of about 5 to 30 minutes. There are specific considerations for flow of the ECPR patient. For example, because ECPR requires rapid cannulation and ECMO access, correct connection of the arterial and venous cannulae to their corresponding limb should be checked using a timeout system prior to initiating flow. One should also consider targeted temperature management for these patients, as well as protection after CPR for the neurologic system. In addition, a search for rapidly reversible causes of cardiac arrest should be identified quickly using echo or cardiac cath, as well as laboratory investigations. Otherwise, the care of the VA ECMO patient and the care of the ECPR ECMO patient are fairly similar in terms of stabilization and weaning criteria. Changing gears, we will talk about respiratory ECMO now. The indications for VV ECMO include high CO2, despite high mechanical respiratory support, blocked airways or acute hypoxemia, severe air leak syndrome, and the need to intubate a patient who's on a lung transplant list. VV ECMO should be considered when the patient's mortality is estimated at greater than 50%. This occurs when the P to F ratio is less than 150 on a FiO2 of 90% on the ventilator. VA ECMO is indicated when the mortality is estimated at greater than 80%, which occurs when the P to F ratio is less than 100 on a FiO2 of 90%. Contraindications for VV ECMO are similar to VA ECMO. Those include multisystem organ failure, acute chronic or acute on chronic, end-stage lung disease without the option to transplant, prolonged ventilation at high settings, advanced age, or cognitive or social issues which may inhibit the patient's ability to participate in rehab. Similar to the SAVE score for VA ECMO, the RESP score, the Respiratory ECMO Survival Prediction Score, estimates a patient's risk of survival or death on VV support and includes several of the following parameters: the patient's age, their immunocompromised status, how long they were intubated, what their diagnosis is, and several other multi-system events. Again, before initiating cannulation strategies, one will want to be sure the correct people are at the bedside. This includes the bedside RN and a lead RN or ECMO specialist, an intensivist, a perfusionist, a respiratory therapist, a surgeon, and assistant. You'll also want to be sure you have antibiotics, anticoagulation, and ultrasound available, as well as a C-arm or TEE if you are considering the use of a dual lumen cannula for VV support. The ECMO box supplies are likewise very similar when considering VA or VV support. When considering VV support, there are multiple configurations which can be used to support the respiratory system. The first is femoral VV ECMO. The second is femoral IJ ECMO. And the third is the use of a dual lumen cannula placed into the IJ. In each of these configurations, one venous limb serves as the drainage cannula and the other serves to return the oxygenated blood to the heart. It's important to note that there is a degree of separation between the two cannulas to avoid recirculation syndrome, which we'll talk about in a minute. Slide 27. Here is an example of the different configurations and different sizes of cannulas that might be needed for each limb of VV support dependent on the patient size. You will want to have these cards made up before you start placing people on ECMO for ease of reference. Again, you will want to have some specific goals in mind after initiating VV ECMO. Blood flow will be between 50 to 80 milliliters per kilogram per minute. SATs would be 88% and above. It's important to make sure that everyone taking care of the patient understands the goal is not to have a 100% SAT, and that a PaO2 of 50 or greater is actually adequate for oxygen delivery as long as the cardiac function is normal. Usually, we decrease the oxygenation on the ventilator to less than 40% while on VV support and allow the patient to rest for the first 24 hours of support, although this may vary quite a bit between institutions. Blood gases are followed serially to titrate both the FiO2 and the sweep on the gas. Just like VA support, there are specific complications for VV support. In addition to things like tamponade or vascular injury, one specific complication is recirculation. This occurs when the two cannulae are too close to one another and the venous return is actually taking back oxygenated blood to the circuit. You'll notice a high SVO2 and a low patient oxygenation, and both the cannulas will appear to be red and well oxygenated. This can be changed by a few maneuvers. The first is to reposition the cannulas to put some more space in between them. You'll see in the picture, the first picture labeled A, there's only 3 centimeters of separation. The second picture, there's more like 8 centimeters. You can follow this on your KUB and chest x-ray as well. The other option would be to switch to a dual lumen cannula or to add another drainage cannula if the patient is large and their oxygenation needs are not being met. VV ECMO is weaned differently from VA ECMO. There are 2 different ways that we can wean from VV support. The first is a similar manner as VA support. We adjust the flow, serially turning it down until we get down to about 1 liter per minute and holding steady there. We follow all of the oxygenation and ventilation parameters to determine if the patient has tolerated the wean before decannulated. The second, which you would never do on VA support, is to adjust the sweep and the oxygenation. You'll serially turn down the FiO2 and the sweep gas until they're off, following all of the other parameters. You don't want to wean at high ventilator settings, just like you don't want to wean at high inotropic settings, as you want to have somewhere to go once your mechanical support is gone. VV decannulation is in some ways much easier than VA cannulation and can typically be done at the bedside. For this, you'll want to have a recipe card as well. You'll need a barrier kit, some towels, some sutures, some sterile dressing, a large ChloraPrep, sterile gloves, and a sterile ECMO decan tray, which would include needle drivers, suture scissors, heavy-duty scissors, and 6 tubing clamps. You'll also want some lidocaine if the patient is awake. Once you've established the patient is ready for decannulation, you'll place your sutures in a figure of 8 fashion around the site of the venous cannula. Following this, you'll come all the way off of ECMO, and you may or may not decide to flush the volume back to the patient. Once this is complete, clamp your cannulae, and with an assistant, pull out the cannula and tie down the figure of 8 sutures. This should be enough for hemostasis. You may briefly lay the patient flat for the removal of the cannula, but you'll want to sit them back up if the cannula is in the neck to allow for decreased venous pressures. We'll also go over this in class. We're looking forward to a productive course with specific focus on getting familiar with the techniques for VA, ECPR, and VV cannulation and decannulation, as well as troubleshooting the ECMO circuit. If you have any questions or suggestions before or after the course, please don't hesitate to reach out. See you soon.